This is Henry Jampel, and I want to thank the organizers for inviting me to participate in this heretical session. The topic title I was assigned was Early Glaucoma Should Not Be Treated, period. I have taken the speaker's prerogative of slightly modifying this title to emphasize the fact that we don't treat glaucoma, we treat the glaucoma patient, and then second, removing period because there are exceptions to this dictum. My argument is as follows. We don't really know what early glaucoma is. Treatment, at least of ocular hypertension, can be delayed without harm. The effectiveness of treatment of early glaucoma is modest. Furthermore, treatment has not been shown to preserve quality of life. Most patients with early glaucoma do not live long enough to lose important vision, and all treatments for glaucoma have side effects. We don't really know what early glaucoma is. Is it elevated intraocular pressure alone? Is it an abnormal disc appearance, or OCT, with a normal visual field? Or must it include visual field loss? This question remains to be answered definitively, but Dr. Quigley and his international colleagues are attempting to provide us all with a better definition of glaucoma. Nevertheless, here is an example I think we can all agree upon. This was a 63-year-old male who I just saw recently. He had been followed for years by an ophthalmologist who told him he was fine. The ophthalmologist retired. He was then seen by an astute optometrist who thought he might have glaucoma and referred the patient. The OCT shows characteristic thinning of the superior retinal nerve fiber layer, accompanied by a corresponding inferior visual field defect. His intraocular pressures were repeatedly between 13 and 16 millimeters of mercury. We will return to him at the end of the talk. Second, the treatment of ocular hypertension can be delayed, and perhaps by extrapolation, early glaucoma. This graph from the Oates study follow-up demonstrates that when the control group, who was not treated for 7 years, then was treated, that its course was no different from that from the subjects who had been treated from the start. Therefore, withholding treatment for 7 years did not adversely affect the subjects who were not treated. 3, the effectiveness of treatment of early glaucoma is modest, at least in the early manifest glaucoma trial. In this trial, patients with early glaucoma were randomized to treatment or observation. At 6 years, the worsening was 49% in the treated group and 63% in the untreated group. This leads to a number needed to treat of 7. In other words, one needed to treat 7 early glaucoma patients to see a beneficial effect in 1. We see a similar phenomenon in the United Kingdom glaucoma treatment study, where patients were randomized to latanoprost or placebo. At 2 years, 15% of the treated group had worsened, and 25% of the untreated group had worsened, for a number needed to treat of 10. 4, treatment has not been shown to preserve quality of life. Again, from the early manifest glaucoma trial, the quality of life at 3 years into the trial was the same in both the treated and the untreated group, both for the composite score and for the subscale scores on the NEI VFQ. 5th, most patients with early glaucoma do not live long enough to go blind. This graph is from Broman and others. They modeled the average age at which glaucoma was diagnosed and compared it to the average age at which a glaucoma patient died, and found that in the worst case scenario for African derived individuals, the average time from glaucoma diagnosis until death was 15 years. For other ethnicities and races, it was less than 15 years. 6, all treatments for glaucoma can have side effects. This graph, also from the EMGT, showed that the onset or progression of cataract was higher in the treated group than in the control group. So, is it ethical to not treat the early glaucoma patient? I would argue yes. The decision to treat should be based upon an analysis of the risks and benefits of treatment, not just the benefits. The EMGT and the UKGTS did demonstrate the benefit of treatment, but they did not offer a risk-benefit analysis. Clearly, any decision whether to observe or treat the patient with early glaucoma should involve the patient in the decision-making process. There are exceptions to the don't treat rule, of course. If the intraocular pressure is really high, the patient should be treated. But recall, many of these patients do not have elevated intraocular pressure. If the patient can't stand the thought of having the disease that is not treated, then the patient should be treated. Or if you observe the patient getting worse over time, or historically, if you know the patient used to be normal and then now has early glaucoma, one would likely treat. In summary, don't treat the early glaucoma patient. The definition is vague. There is time to treat later. The treatment effect is modest. There is no evidence that treatment affects quality of life. Most patients won't live long enough to lose important vision, and treatment has side effects. And the patient from earlier, after extended discussion, he elected to be treated. I prescribed latanoprost for the right eye and scheduled a return visit in 3 months with repeat visual field testing. 3 hours later, he called me and wondered if he could hold off on the eye drops for now. And of course, I told him yes. Thank you for your attention.